disclosure is none relevant to today. I like talking about the cerebral palsy definition when we talk about genetics. This is a rough paraphrase of the 2006 definition. It's a lifelong motor disability due to non-progressive disturbance in the developing fetal or infant brain. And this concept of non-progressive disturbance has caused a lot of consternation for clinicians in terms of trying to understand genetic causes of CP. When we ask clinicians whether they would diagnose cerebral palsy in a set of scenarios, in this paper, we surveyed a group of physicians and asked them across the US and Canada how they would diagnose cerebral palsy in a few different scenarios. In one scenario, we presented to them a child who was 5 years old, who was born premature at 30 weeks, had periventricular leukomalacia, so a type of brain injury that's very commonly seen in people born premature. We didn't indicate that this child had any genetic cause, but we made sure to say that he didn't have any loss of motor milestones. He was gaining motor milestones as he got older, and he had spastic diplegia, or increased tone. So almost everybody said this kid got a CP diagnosis. This 5-year-old had a CP diagnosis. I would hope so. This felt like this is, should be a solid CP diagnosis situation. Then we said, well, actually, this child has been losing motor milestones. We think his spasticity is getting worse. Would you diagnose this child with cerebral palsy? And very few people did. That makes sense. It feels like he's losing skills. Maybe there could be a different condition going on that's different from cerebral palsy. Then we repeated the first scenario, same exact scenario, but we said this child had a genetic cause. Everything else was exactly the same. And the percentage of people that would allow that child to have a cerebral palsy diagnosis dropped. This paper came out a few years ago, and I poll audiences when I give talks, how many of you would diagnose, how many of you would diagnose. This percentage has roughly stayed flat. At about 70% of people would diagnose a child with a genetic cause of a true cerebral palsy phenotype with cerebral palsy. And when we asked people specifically why, they said they wouldn't diagnose CP if there was a genetic cause, which, as maybe some of you have heard earlier on in the conference, is a little bit confusing to many of us. There can be many causes of cerebral palsy, including genetic causes. And that has been reaffirmed numerous times, including in that 2006 definition, that a genetic cause does not exclude a cerebral palsy diagnosis. This becomes particularly important in adults with cerebral palsy who may have never had access to genetic testing and are now in a medical care situation where they may be unfortunately struggling to get any care at all, let alone having anybody understand what the cause of their cerebral palsy ever was. So thinking about genetics of cerebral palsy is really important, maybe particularly in that population that never had access to genetic testing. And it turns out it's pretty common to have a genetic contributor to your cerebral palsy. Depending on the study, roughly about 30% of people with cerebral palsy have a genetic contributor. So that could mean that you have all of your cerebral palsy is caused by a genetic cause, or it could mean that you have you've been born premature and could also have a genetic cause, and that those factors combined lead to the cerebral palsy phenotype, or how your cerebral palsy looks. And if we look just at people that have factors, environmental factors, that otherwise increase the likelihood that they'd have CP, so prematurity, being born at term and having HIE or hypoxic ischemic encephalopathy at birth, or some other birth injury. Even if we look at that population of people, 8% of that population of people have a potential genetic contributor to their cerebral palsy. And the data on this grows and grows. So there are a number of papers now that have identified numerous single gene etiologies for cerebral palsy. One of the most common causes that have been identified across multiple studies is this particular gene called 4A1. I could talk about each of these genes individually, and I'm happy to for people who have questions, but I wanted to focus on this one in particular because it is a condition that predisposes people to an increased risk of brain bleeds. So if you think about a child that's had an intraventricular hemorrhage and that's the cause of their cerebral palsy, sometimes it could be prematurity, Sometimes it could not. It could be a genetic mutation. Sometimes it could be both. So thinking about genetic causes of even injury-based cerebral palsy is important. And one might say, who cares? You know, if your child has a brain injury that leads to cerebral palsy, or if you personally have a brain injury that's causing your cerebral palsy, why do I care what caused the brain injury, or why do I care what my cerebral palsy was caused by? In the case of many genetic conditions, if you have a genetic predisposition to cerebral palsy, you can have a genetic predisposition to other things that go along with that gene. So identifying the gene can be really valuable to think about screening requirements. What are things that we need to screen for, and do we need to start screening for them earlier because of a particular genetic condition that you may have or that your family member may have? And what we're learning is that that ends up being the most common benefit to identifying a genetic condition in someone with cerebral palsy, is that it can change screening recommendations for other conditions that can really modify your quality of life. For these reasons, the American College of Medical Genetics, and this paper came out a few years ago as well in 2021, looked across all of the data for people with childhood-onset disabilities, intellectual disabilities, and developmental disabilities, including cerebral palsy, and recommended that genetic testing is a first-line diagnostic evaluation for people with developmental disabilities. And across all of these studies, they found that the reason they were recommending this is that genetic testing could change short or long-term management for someone 8 to 10% of the time. And this is beyond counseling for family planning, which I think a lot of people talk about with genetic testing, family planning, and I'm sure when you're sitting in clinic with your 10-year-old, you're like, okay, I don't really care about my 10-year-old's family planning right now, and I'm done having kids, so why do I need to have genetic testing? It's that screening recommendation that really changes depending on the genetic finding that you identify. Rarely it also changes treatment recommendations, but I don't usually counsel families that way, that we're expecting a specific treatment to come out of a genetic test result, but we can often get screening guidelines for things that we need to look for based on a genetic test result. So when I say genetic testing, it actually means a bunch of different things. Not all genetic testing is the same. So a quick crash course on what this means. We are all blends of our parents and also independent of our parents, so obviously. So I tell my families that we're all mutants, we're all X-Men, and I'm a little bit of my mom and I'm a little bit of my dad, but my nose is not quite like either of them. So, but maybe my hair is exactly like my mom's and my skin's exactly like my dad's. And I say that because there are parts of them that are inherent to me and there are parts that are uniquely me. Any of those parts combined can be a genetic condition, can lead to a genetic condition that predisposes you to cerebral palsy. So a genetic condition need not be inherited. It can be something that's unique to you. It's called de novo. So when we're thinking about genetic testing, at any level, anything that we find that could contribute to cerebral palsy phenotype could be unique to you. It could be from mom, it could be from dad, or it could be from both parents. At each level of the things you inherit from your parents, at kind of the most broad level for genetics, you inherit chromosomes. So you have 23 pairs, one set from mom, one set from dad. When we think about this at a genetic testing level, this is where something called a CMA, or chromosomal microarray, comes in, where you look at in some ways the structure of a chromosome. That's an additional thing called a karyotype. But you also look at the number of times parts of a chromosome are deleted, or extra parts of chromosomes. It's called copy number variations, and CMAs are very good at finding those things. But within chromosomes is this classic sort of double helix that we think about, this DNA structure that I think we see a lot when we think about genetics. But when we think about this DNA structure, and we're thinking about genetic testing, we actually think about it as more of a rectangle than this beautiful double helix, because all of this DNA can be broken down into two general categories when it comes to genetic testing, exons and introns. So exons are the part of your DNA that are all smushed together to make chromosomes, but then if you unravel that smush and you come out with this long section of exons and introns, exons are the part of your DNA that eventually codes for proteins. So these are, the recipes in your cookbook that if you make them, make up parts of your cell and make up who you are. The introns are the parts of DNA that help tell your body when to make which exon. Does that make sense? So the exons are what actually gets made, and the introns help tell your body which exons to make when. So you can imagine that issues with either exons or introns or both could contribute to the way my nose looks, the way your hair looks, or to cerebral palsy. It could be any of these things. When you think about a gene panel, which are becoming less and less common these days, but are still out there, a gene panel looks at a subset of exons. So there may be certain exons that have been shown to be associated with dystonia, for example. So there's a dystonia gene panel, and that could test for 12 different exons, sequence 12 different exons. But if you have a cause of dystonia or a cause of cerebral palsy that's not in those 12 exons, you're out of luck. It's not going to be in that gene panel. The next thing you could do is whole exome sequencing. Now, whole exome sequencing looks at all of the exons you have, every single one, but it does miss those introns. But it turns out that you can catch a lot of causes of cerebral palsy by looking at every single exon. Every single recipe in that cookbook, if you were to read it, maybe there's a typo somewhere, and that could lead to cerebral palsy. So it does catch all of those exons. The caveat to whole exome sequencing is that it's based on our knowledge of what each of those exons do. So if we don't know what this green exon does, if nobody knows what it does, then you could do whole exome sequencing, you could find a variant in that green exon, and you may not know that that is what caused your cerebral palsy because nobody has linked that green exon to cerebral palsy before. That'll come up a little bit later as to why that's important. Everything we do with whole exome sequencing is based on our knowledge right now of what exons do. So as we get new knowledge about what exons do over time, the value of whole exome sequencing shifts every few years. The last type of genetic testing that we're hearing more and more about is whole genome sequencing. Now, whole genome sequencing includes the exons and the introns, and certain types of whole genome sequencing and whole exome sequencing now also includes these copy number variants from CMAs, the big deletions and the big duplications from CMAs that historically we would only be able to get from CMAs alone. So more and more, we're seeing people shift to saying you should get either whole exome sequencing or, even better, whole genome sequencing when we're talking about genetic testing for a developmental disability like cerebral palsy. With that in mind, I want to talk about this lovely work from one of our colleagues at Boston Children's, aggregating all of the available information we had on whole exome sequencing and chromosomal microarray in people with cerebral palsy. And across studies, SID found that the diagnostic yield of a whole exome is about 23%, meaning that for people that had whole exome sent who had a cerebral palsy phenotype, about 23% had a finding, had a genetic contributor found on whole exome, that the yield of a chromosomal microarray was about 7%. Now, this figure shifts depending on the population that you study. In aggregate, it's safe to probably say about 10 to 15% of people are likely to get, of people with cerebral palsy, you might expect 10 to 15% to have a genetic finding on a genetic study like whole exome sequencing. Based on this work, there's a growing push to have whole exome or whole genome be a first-line diagnostic evaluation in people with cerebral palsy. The other thing that was suggested in this paper was the concept of a trio. So I told you before that we're all X-Men, we're all mutants, we're part mom, part dad, part us. The trio is sending genetic information from mom, from dad, and from the child, all three together. That's the trio. If you have a sibling for whom you can send genetic information, a biological sibling, that's called a quad. the more information you can send about a family, the more we can find out about what genetic information is from mom alone, from dad alone, and uniquely you. The reason that's important is because we don't know what all of those exons do. So if we see a variant in that green exon, for example, and that same variant was in mom, and mom doesn't have cerebral palsy, it gives us some confidence that that green exon probably doesn't cause cerebral palsy. So that's why the trio is important. There's just too much genetic information for us to know everything about everything right now. So we learn from mom and dad, just like we learn from mom and dad in clinic, we learn from your genetic information too when we're analyzing the whole exome sequencing. And the reanalysis is critical, right? Because every day, literally every day, we're learning what one more exon does. We're learning what one more intron does. And that's why when you have whole exome sequencing done, you should, it should really be automatic that your physician is talking to you every 2 to 3 years about having it reanalyzed. Now, what does reanalysis means? It means calling up the company that did the whole exome and saying, can you run the data again using the information we have now? It's not new blood tests, it's not a new cheek swab, it's not a new trio, it's not anything new from you. It's calling up the company and saying, run it again, run the analysis again. And that should roughly be done every 2 to 3 years based on the pace of information or knowledge that we're gaining about genetic information at the time. So based on all of this information, maybe I should have this as a disclosure or a disclaimer, I'm a neurologist. So the American Academy of Neurology, at our urging, has advanced a quality measure saying that people with developmental disabilities or epilepsy, and this includes cerebral palsy, should have genetic testing discussed as a part of their evaluation. Now, it was hard for us practically to say that everybody should get whole exome sequencing done for a variety of sociopolitical reasons, honestly, but we should at least be talking about it with all of our families and seeing if there's a way to facilitate a pathway to getting that genetic testing done, as long as a family is understanding and interested in pursuing that information, given all of the information we have about genetic testing right now. So what do families think about genetic diagnoses and what that means for a cerebral palsy label? We asked them in the US and Canada through 2 foundations, the Cerebral Palsy Research Network and a foundation called Simon Searchlight that's done a lot with families affected by autism. And many of you may know that there are a lot of people that have autism and cerebral palsy, that you can have both. And so they have a database of people interested in research who are affected by autism. A lot of those people also have cerebral palsy. So we looked across both of these databases and we asked families, what do you value knowing the cause of your CP? And how many of you have been told the cause? So there's a gap there. The majority of people said they did value knowing the cause of their CP, but less than half had been told the cause of their CP. And the majority also said they preferred carrying a cerebral palsy diagnosis together with an etiologic diagnosis. And you may have heard some discussion of this yesterday, this concept of saying you have cerebral palsy caused by, not caused by this genetic condition. Not you now have a genetic condition, so you no longer have cerebral palsy. The reason families felt that it was valuable to keep a cerebral palsy diagnosis, even if given a more specific genetic etiology, or even if given a genetic etiology, was because they felt that a cerebral palsy diagnosis allowed them to better understand how their symptoms would evolve. And I just want to pause and highlight the importance of that. When we say someone has had continued gain of motor milestones in childhood, that population of people, we tend to know how their motor development progresses through the rest of childhood at least, and we're learning more and more about how their motor development or motor outcomes progress in adulthood. We don't know as much about individual genetic conditions. So to say you now have this genetic condition, congratulations, it's much more specific. There are 5 people affected by the same genetic condition in the world. You guys get together and create a foundation so we can learn more. That's very different from saying that you have cerebral palsy, it's it's due to this genetic condition, but a lot of the same things that people affected by cerebral palsy, that happen for people affected by cerebral palsy still apply to you. That's a really important concept. It guides treatment and it guides an understanding of your own ability to plan for your future. Families also said that a cerebral palsy diagnosis gave them the ability to explain their symptoms better, or an ability to explain their symptoms at all to others, as opposed to having kind of an alphabet soup genetic diagnosis to share with other people. Of course, a cerebral palsy diagnosis gives you access to services, and it also gave people an access to a community, and in many cases a much larger community of people going through shared lived experiences compared to an individual genetic or other etiologic diagnosis alone. So in summary, I usually do the summary for clinicians, but I'm thinking about this. I changed it a little bit for families to urge you all to bring up genetic testing in clinic visits. There's a lot of self-advocacy that I think families with CP have to do in clinic, and this is one of them, while clinicians, I think, catch up to the vast amounts of data that's out there. Ask if genetic testing is something that should be considered for you, and if not, why not? Ask about it. If you don't know what caused your CP, or if you don't know what caused your child's CP, ask. I cannot tell you, this is something I pride myself on, right? I wrote a paper about it. I asked all of you and wrote a paper about it, that it's very important to determine the cause of someone's CP and to tell them. It's very important to tell them. When we asked people in our own clinic, we said that about 13% of the people in our clinic didn't have a known cause for their CP. When we asked families, 31% of our families said they didn't know the cause of their CP. So that's pretty sobering for me. And for some families, it was situations where I thought I had explained the cause. But when you're thinking about, again, the clinic visit, there are a couple of kids running around in there, therapist is coming in and out, I'm typing and as I'm typing, I'm talking to you about the cause of your CP. I mean, there's a lot that can get missed in that chaos of a clinic visit. I try and talk about this at every visit, but I would also love for families to ask if there's something they don't know. I would love to address these questions with you. And also know that identifying genetic conditions is not just, an intellectual exercise for research purposes. I only offer things to my families that I think will change management, and I think genetic testing can change management, and we know the data is there that it can change management up to 10% of the time based on those screening recommendations that come with certain genetic findings. So that's all I have. With that, I'll take questions. Thank you. Yes.
Hold on 1 second for me.
Yes.
1 second.
So, question about the reanalysis of the whole exome sequencing. Once you have those results, if you've switched positions, can that request come just from the family directly to the company, one? And two, how do you get that covered and paid? Is that because they're just reanalyzing old data, is that paid for by insurance? Do you have any insight into kind of logistically how you do that?
Yeah, so the reanalysis coverage is variable by state and insurance company, but it does tend to be covered if the original exome was covered. The cost of exome and reanalysis is coming down quite a bit. In some cases, reanalysis can be $100 or so, depending on how many different sequences you're going after reanalyzing. Can a family call and ask for reanalysis? Yes. I think the only thing I would suggest in terms of asking for reanalysis is that sometimes there are new things that come up for your child that are valuable in knowing for the reanalysis, and I'll give you an example, and I'll use dystonia because that's what I see a lot of. If dystonia has not previously been identified in your child, and then in the last couple of years they have that new diagnosis, that new information can guide what sort of exons people are saying contribute to the specific pattern of movement that your child has. So I think you can ask for it on your own, but I would try to ask for it in collaboration with your physician so that any new medical information that can inform the reanalysis gets to the company as well. Great. Okay, thank you. It's my youngest scientist in the middle.
To scan that QR code and fill out the eval before you leave today. And so I'm thrilled to come up here and introduce our final presentation for the day. I'm Lynn Fogel, by the way, and I'm a member of the Community Council. And I'm happy to introduce Dr. Croteau this afternoon to talk about physiatry. The presentation is called A Physiatrist for Life. And when we were talking amongst our council about the kinds of presentations we wanted to have, the topic came up, and we said, let's find a physiatrist to talk about this. What is a physiatrist? What do they do? And what can we expect from a physiatrist for our child or for ourselves throughout their lifespan? So this session is in response to that. It's an overview of the role of physiatry across the lifespan, and we're thrilled to have Dr. Croteau here talking with us. She is a local physiatrist practicing here in Quebec. She actually had an important role as a local host for the whole AACPDM meeting this year here. She is a member of the Adapted Sports and Recreation Committee. You may have seen her come in earlier and speak when we had that presentation a little bit earlier. And her interests include CP, transition, gait lab, and adapted sports. So thank you so much for being here, Dr. Croteau.
Thanks for the introduction, and thanks for the invitation. It's really a pleasure to be able to present about my own specialty here in Quebec. As you can hear, English is not my first language, so sometimes I'm not as fluent as I would like to be in English. And so if I'm not clear, maybe I will not use the good words, so you can interrupt me and ask me to repeat, so I will not be shocked, or it's really okay. I would love to be better in English or more comfortable with English. So the slides will be in French because first I was supposed to present in French, but I think it will be easier to stick with English. So my objectives for today is to talk to you about my specialty, physiatry, also to talk about the place we can or the role we can have for someone with cerebral palsy, including during the adult age, and at the end I want to keep some time for a discussion or to answer your questions, so I will try to respect time, it's sometimes hard for me. So I don't have any conflict of interest, but I'm really interested with the topic I'm talking to you about today. And as we said, I'm a member of the Adapted Sport and Recreation Committee. So for me, sports and recreation, art therapies, so, and are really, really important. And literature supported too, so yeah, this is my disclosure. So what is a physiatrist? And I only have a kind of 20 minutes, so even my families are still asking me, what is your job? What kind of doctor are you? So to kind of guide or to organize my presentation today, I was inspired by that podcast, so I strongly recommend you to listen to it. It's Jennifer Lineman. Do I pronounce her name right? Yeah. With Dr. Wendy Pierce, who is a pediatric PM&R in the United States. So if you want more information about my specialty, it's another way to learn more about it. So sometimes we say PM&R, sometimes we say physiatrist, sometimes we say physical medicine and rehabilitation. So they are all synonyms. And we are doctors, so it will be on my other slide. So we are not a PT, we're not a kinesiologist, so we do our medical studies, and our specialty is PM&R. It's the word I will use mainly today. And we are kind of a new specialty. Around 1930, we were the one interested by movement and action. So compared to the orthopedist who are known to be interested by bones and joints. So it was we were already interested by function or by activities at that time. And with the Second World War, with amputees and polytrauma, so we became the doctor interested by rehabilitation and adaptation. So it's where the discipline became bigger and bigger at that time. So we are there to treat, but we are also there to do prevention because we know the evolution of the conditions we are following through lifespan. So we are able also to try and to screen at the right moment, like we said with genetics, to try to diagnose the complication and be able to treat them as early as possible when they happen, to limit the impact they can have on function and participation. So we are really thinking, our DNA is to think about function, participation, being independent, and being able to do everything we want to do. So sometimes it's regularly, sometimes it's with adaptation, and I will come back to that later, but we are really thinking and focusing on function and participation. And as we said, we are doctors, and to be able to think about function and participation, we have to look at the whole picture. So we have to think about the environment, the parents, what we have access, and what the person like, what are their values, their interests. So our recommendations are usually something that is individualized, and so we want to know who we treat to be able to give the good advice to that particular person. And we work in teams. I mean, I don't have the same value when I'm solo in my office than when I have a PT with me, an OT, and other member of the rehabilitation team. So together we can use all our expertise and give something even bigger that everyone can give when they do it by themselves. So this is also the strength or the way we work. And about our training, a physiatrist, most of their training is with adults. So I think it's a reason why also during the adult years of someone with CPR, developmental condition, or pediatric condition, the physiatrist is someone who is important because during the regular training, we do only, I would say in Canada, it's only 3 months of pediatric rotation that we are doing. The rest is with adult population, and I did an extra year, so a fellowship to become a pediatric physiatrist, so to get more knowledge with the pediatric population. So a physiatrist is someone who is used to work with adults. And I will not go in detail with that because they've been presented this morning by another speaker, but it's really the way we look at every medical conditions and everything. So yes, we want to have a look at range of motion and anatomy and organic function, but we also want to know what kind of impact it have on walking, ambulation, dressing, eating, bathing, and moreover, if it has has an impact to go to gym class, to go to school, to go to work, to participate or do activities in the community, and see what kind of factors that are positive and negative can be there in the environment, and the personal factor that can have an influence on the condition and the functioning. And as you saw this morning, I mean, pediatric neurologists, pediatrician, developmental pediatrists also use that kind of thinking or use that framework to do their work. But I would say in the adult world, we're probably the only specialty who continue to use it. And the same thing, the F words have been created for the children, but I think, and I'm convinced that even for adults, it's still meaningful, and we should still think about fitness, function, friends, family, fun, and the future. And there's two main branches in physiatry and PM&R. So there's some doctors who are mainly doing rehab, and it's with cerebral palsy, but also with traumatic brain injuries, spinal cord injuries, amputees, and other condition with the physical disability. But also there's a branch doing mainly musculoskeletal and sport medicine, including athletes and para-athletes. So, and some are doing a more general practice, a little bit of both. And it depends mainly, or usually, if you are in a university setting where you can specialize in something because you are inside a big group, or if you are more in a rural or a small place and you have to cover everything that the specialty can offer. And yeah, I mentioned about the specialties and CP, and I will discuss about CP a little bit more on this slide. So we think about, we are doctors, so health is important in all aspects or all systems, so bones, and Sabrina talked about her stress fracture she had during the Paralympics in 2016. So we try to prevent that, and when it happens, we try to get it healing as fast as possible and give recommendation according to that. We cares about the joints, so the range of motion and pain, and the impact it can have on function. Muscles, we also think, can we help this patient to get stronger, to get more endurance, to be, or to walk more? We also are really picky doctor. Maybe you realize that during appointments, but we don't just want that people are walking or bathing or doing things on their own, but we want them to do it as good as possible, and this is to prevent complication along the way. So to prevent pain, to prevent overuse injuries. So sometimes we are happy to see a child walking or an adult walking, but we also try to find if it's orthosis, adaptation, strengthening program, or exercise that can help to improve the gait pattern or the activity to realize it as good as possible. So I talked about pain, also skin issues, especially for people who are in wheelchair, because they are sitting a lot of time during the day and increase the risk of skin issues. Also constipation, so sleep, but it's a non-exhaustive list of the health impact that cerebral palsy or other neurodevelopmental condition can have, and we are trying to address. As we said, we prescribe a lot of adapted equipment, including orthosis, gait aids, equipment for positioning, wheelchair. So we try to keep up to date with what is on the market because it's evolving really quickly. So it's something we can offer. And as I said, we want to increase participation, or we want our patient can participate in everything they want at school, at work, with the family, with friends, and in the society. And I would maybe skip that part to go to the adult years. But yeah, we have a role during the infancy, but because we talk about lifespan, and I don't want to come back too much with this one, but we have to keep up to date with all the literature and all the evidence to support rehabilitation techniques, but also injections. So I forgot that part, but we, in our toolkits, most of the physiatrists are treating spasticity and dystonia, so including the non-medical or non-pharmacological ways to address spasticity and dystonia, including braces and stretches, exercise, strengthening, the oral medication. So we are used to prescribe it. Most of us are doing the injection with botulinum toxin, some are doing phenols, and we're also there to think, okay, is my patient at the point it's a surgery that is needed, and is it a neuro or surgery of the nerve or surgery of the bones and muscles? So even if we don't do those techniques, we can be someone who help to decide, okay, at this point we need to ask a surgeon if he thinks it's the time to offer a surgery. And transition, and this is, I think it's not that bad in the US, but in Canada it's still a big issue. Oh, it's bad. I was hoping it was better in the US because it's sometimes the feeling I have when my patient turn 18 or 21, because depending, I go to an adapted school that's named Madeleine Bergeron, and there I can follow the patient up to they turn 21, but if not, it's at 18 in Quebec that you become an adult and to have to be transitioned to the adult system of care. So, and I really want, and it's getting better, but it's this division of transition and the feeling I want to have when my patient turn 18 or 21, and I know someone will wait for them on the other side and will continue to follow them. And this is especially true for cerebral palsy and neurodevelopmental condition that start in the pediatric years, because we know that with growth there are many issues that can arise and we have surveillance to do, but we now also know that during the adult years, and it's most of their life, and it's my next slide, but there's other conditions that we have to continue to screen, maybe not as often, but we continue to have a place and a role in prevention and treating. So, and I think a physiatrist is at a good place to do it. Unfortunately, we are not many, and from my colleagues who are physiatrists in the adult world, now it's part of my job to explain to them why they should follow patients with cerebral palsy and to interest them to that population, and it's because we are not many. In Quebec, we are almost 8 million of population, and we are less than 100 physiatrists, so we are really not a lot for the population we deserve. But yeah, and on my slide, what is important on this, it's over the last 20 or 30 years, the life expectancy of people with cerebral palsy increased a lot. So now there's, for one children with cerebral palsy, there's 3 adults. So there's more adults than children, and it's true for many other conditions. So the numbers are there, the needs are there, and in 2009, they had that special edition of Developmental Medicine and Children Neurology journal addressing the adult needs, and the evidence are growing, and we're more knowing what can happen during the adult years. So when growth is over, it's not over. You still have your cerebral palsy, and you can have other challenges that need to be addressed and prevent. So this is the role of adult physical medicine and rehabilitation doctors. So at the adult age, the way I see it is we have to collaborate with family physicians. We are not someone who will replace a family physician. I think everyone needs one, but we have to be there to address the issues that the family physician is not comfortable with. And I think the best model is also to have, maybe not as often as during the children years, but we have to do kind of a surveillance every year or every other year to be sure everything is on track, everything is going well, and address the issues, and be also available to see the patient as needed if a specific issue happened, like a surgery, like a fracture, and even that was not planned, and spasticity increase or pain appears or positioning need to be readdressed, and so it's not because I said with the numbers we can't do the same kind of follow-up as during the children years, but I think it's really still important because we can offer broad services or help with many things, and a family physician they are good doctors, and I would not be able to address diabetes or hypertension. So I can do their job, but probably in their population they are deserving. There's maybe one or two patients with cerebral palsy, so they can't be the expert of all the complication that can happen during adult years. And the other role we have, it's advocate. So, and if you have cerebral palsy or if you have a children with cerebral palsy, when you go see a physiatrist or a PMN or doctor, I think knowing what we can do, you can use the good words, or you can give us the information, because a medical appointment can be not long enough to discuss about everything. So if you come to our office with your priorities, we will try to respect that and address what is important for you, what is the issues at that moment, and we will also do our usual screening and your bread and butter. But we really appreciate when families and patients come to the appointment and ready to come see us, because we feel we are more effective or more useful when we can also address what is important for patients and families. And how can we find, I mean, there's not a perfect way to find a PMN or doctor in your area, but I have some suggestions that you can explore. So once there's the site of the AACPDM association, so there's a list and you can see, but it's not all the PMN or doctor who are registered or member of the AACPDM, but the one who are, you can see in which part of your country they work, so it's a way to find some. In Canada, it's CAPMNR, with the Canadian Association of Physical Medicine and Rehabilitation, but again, not all the PMNR doctors are member of that association, but you can find some. In US, it's the AAPMNR, and the same thing on the website. You can try to find a doctor with your area or your it's not province in your states. So, and in Quebec, it's APQ, so Association des Physiatres du Québec. But the other way I recommend you to look for a PMNR doctor is go to the closest rehab center because usually they know who are the PMNR doctor in their area, and there's also the CP Foundation that have contact and know a lot about the resources in the States and in Canada. So it's the other ways to try to find a doctor, because family physicians don't always know if there's a PMNR doctor in their area or in their town or in their province or in their state. So I would like to keep time for questions. There's no wrong questions. It's my answer that could be more challenging. So I would really be happy to answer to your question if you have any. And yeah. Do you have, just wait for the mic maybe.
1, 2.
It almost seems like a specialty, like someone like you across the lifespan, because I think this is a huge issue. Where do they go? And, you know.
Yeah, and I tried, as I said, in Quebec we are 2 PMNR working with children, and we try to set an adult clinic or a transition clinic, but we have so long waiting lists for children, so we had to choose if we decide to have a longer waiting list for children and adults, or if we focus on children and try to get a new partner to do the adult population and have that person doing only this, so this one will become the specialist for the adult with CP. So yeah, we took that decision. I know that at other places, the one who are doing the pediatrics continue to care for adults and it's feasible, but yeah, we didn't choose to work that way in Quebec.
That was lovely. Thank you. I'm curious. My heart calls me in a similar direction in terms of lifespan care. For us, the issue was that I work in a hospital that otherwise has pediatric specialists in it, and so if I were to take care of my families throughout a person's lifespan for cerebral palsy, and they were to have an emergent issue, what emergency room do they go to? You know, so that ended up being the issue for us. I don't know if you faced those sorts of issues in terms of if they're seeing you for PMR care across the lifespan, are there, who do you collaborate with for emergent care for other healthcare needs?
Yeah, because in Quebec it's a public system, so I mean they will be brought to the hospital that is closer to where they are, so it's not choosing an hospital, but usually you go where it's the closest and all the services should be there, and if they are not, they will transfer you in another hospital where your needs will be better met. But yeah, we don't have that kind of situation here in Quebec and Canada because of our public healthcare system. Yeah, but yes, it's an issue and it's really hard. And as I said, I give you some clues to find PM&R docs, but there's no full registry, and I know no one knows all the resources, and it's changing all the time. So even if they had a registry, it would be probably hard to keep up to date. But unfortunately, I mean, in Canada, we doesn't have this at this time.
I have a question.
Yeah.
Can you give an example of something that an adult physiatrist would be looking at or for in a person with CP that maybe a pediatric physiatrist wouldn't?
Yeah, but one of the thing is pregnancy. So during pregnancy, you take some, I would say, a lot of weight in a short period of time, so it can have an impact on ambulation, on spasticity, on your joints, and if the patient is walking, so can have knee pain, ankle pain, and you can even lose function during that period because it changed the way your body moves. So, and it's really, it happens sometimes that children have babies, but usually it's during the adult life that it happens. So they would be really better than me and know the resources, because there's also OT who are specialized with adaptation and also thinking about will that person will need adaptation to be able to care for the baby. So this is an issue that is almost unique to adults and PM&R. Yeah. And the other one, I will address it quickly, but it's aging. Now we know that person with cerebral palsy doesn't age the same way, but it's the same. I mean, people with spinal cord injury also doesn't age the same way as, I don't like that word, but normal or typical person. But and it's true. So we have to think or use the knowledge that we have to be sure that when pain arises, or if there's osteoarthritis, or I would call it complication arise, we should not just say, okay, it's normal, it's the normal evolution of the condition, but we also have to address it. So, because sometimes, yeah, family physician, and as I said, it's because it's not their expertise, they would say, I think it's normal that this is happening, but even it's maybe normal, we have to do something, and we are usually the one who can help with that. So if there's no more questions, thanks again for coming today. And share the words that I've been recording, so it will be available, and even the last year conference is still available, so for a really long period of time, so it's for everyone. So I think it can be useful for many families, and yeah, that's why we are doing it today. Yeah. I don't know if you want to add something to finish. It's your day.
Nope, that's it. I'll just say thank you again for coming out. Thank you again, Dr. Croteau, for speaking, and everyone else who's had a part of the day. Look for it in a little while online.